Good afternoon. I know we're still sort of drawing on our lovely lunch spread that Anna has secured for us. But I want to go ahead and get us started because we're so interested in the work of Josh. So I want to thank you for being here today. I'm Kate Cagney. I direct the Institute for Social Research, and I'm delighted to welcome you to this session of the ISR Insight Speaker Series. Many of you, are regular attendees, but I just want to say it's a way of opening our doors at ISR, sharing the innovative work our faculty are doing to understand, improve the world around us, and so we really want to make sure we showcase that work, and today is a terrific example. So with over 300 affiliated faculty, ISR research spans an incredible range of topics from wealth inequality, racial justice, to political opinion, aging and health, and what's really interesting today is we're going to think about sensory kinds of measures as, an impact on that. You can find the full schedule of our upcoming Insights talks as well as recordings of past events on our website at isr.umich.edu. Today's talk will be recorded, will be posted there as well, so you can always share it with your colleagues, and you can revisit it yourself. So it's my pleasure to introduce today's speaker, Josh Ehrlich, who's well known to many of us. Josh is the Paul R. Lichter Research Professor of Ophthalmology and Visual Sciences, Research Associate Professor in the Survey Research Center, and the Associate Director of the Center for Global Health Equity. As an ophthalmologist and population health researcher, his research is focused on understanding and addressing the adverse impact of vision impairment and blindness on health, disability, and quality of life, with a particular focus on older adult well-being. In this talk, Josh will introduce us to the longitudinal study of health and aging in Kenya, LOSHAK, which was developed to collect data on health and economic well-being among older Kenyans. So LOSHAK is harmonized with other studies in the health and retirement study, HRS, a suite of studies, and a Harmonized Cognitive Assessment Protocol, HCAP. And this study is developed as an important resource for policy, public health, economic planners in Kenya, and the region as they aim to address the varied social, health, and economic consequences of aging populations. And I'm sure the kinds of measures you're engaged in also provide important feedback to the HRS suite of studies. So with that, just note that we'll take question and answers at the end of the presentation. Catherine will be tying us up then, but we really look forward to a lively conversation. Please join me in welcoming Josh.
Yes, it's working. Great. Well, thank you so much, Kate, for the very kind introduction. And it's really a pleasure to be here today and get to discuss with the ISR community what we're doing in LOSHAK, which needless to say, our team is very excited about. And we're just at the point where we're starting to get the word out more broadly. And a couple other thank yous to begin with. I'd like to thank Kelly for Kelly's our project manager, sitting in the front row here for LOSHAK, and she's been instrumental in so many aspects of the project to date, as well as for helping me put together what I'll be talking about today with you guys. The other obvious big thank you is to our funders, particularly the Center for Global Health Equity here at University of Michigan, which was really instrumental in seeding this project years ago, which I'll talk about, as well as the National Institute on Aging, which provides the bulk of funding for the longitudinal study of health and aging in Kenya, or LOSHAK. And this is just a bit of an agenda of what we'll be talking about today. I'll start with a little bit of background and an introduction to LOSHAK and to really sort of the demography and some of the issues that underlie the need for LOSHAK. We'll talk about Sub-Saharan Africa broadly and Kenya more specifically. I'll talk about the HRS and HCAP networks that Kate was just alluding to. And then I'll talk about the feasibility study. This was an R21 funded study by NIA that we carried out antecedent to the current funding and current phase that we're in. And we'll talk about some of those results and some of the learnings that came out of the feasibility work. And then I'll talk about where we are now in terms of the Wave 1 LOSHAK, both the core and the HCAP study, and how we're thinking about how those studies come together with one another. I'll also focus a bit on lessons for U.S. health that we can take from Kenya and why it's important for us to be thinking along those lines. And we'll have plenty of time at the end for questions and answers. I was told that it's easier if we wait till the end. I personally am okay with interruptions, but we'll wait till the end to make things easy. So Global life expectancy by country is illustrated here in this figure. And what we notice, what's illustrated here really is that Africa remains the region of the world with the lowest life expectancy. It was 62.7 years in 2020. But it's also experienced the biggest gains recently, the largest life expectancy gain and the largest percent gain over the past decade. Underlying these trends are increased healthcare expenditures across many countries, increased access to care, including quite significantly to HIV care and antiretroviral therapy in many countries, targeted treatment of other infectious diseases like TB and malaria, rising incomes and educational attainment across many countries, as well as urbanization. And there's been relatively less widespread famine compared to earlier decades. And in many regions of Africa, less armed conflict. Hopefully it will stay that way. All of these together have led to an increase in longevity and also to decreases in maternal and under 5 mortality. And so we see this life expectancy increasing. We also know that fertility has gone down in many African countries. And along these lines, we see global population trends where we're seeing aging in all regions. The 2.1 billion people over age 60 in 2050 represents a doubling compared to 2020. This is globally, not just Africa. But what we see is that 80% of older people by 2050 are going to be in low and middle income countries. And that's a real change from where we are right now. And Africa will sustain, of all regions, the largest of these increases, as illustrated here in this report from just a year or so ago by the U.S. Census Bureau. Now, these maps illustrate the magnitude of population aging that's projected by country, as well as variation in the timing and rate of this phenomenon across the continent. And we can see sort of, there are a lot of countries kind of, with the exception being the very south and very north of Africa, that have a very young population in 2020. But we see that by 2050, there's a pretty precipitous change in that. And I'll provide some more Kenya-specific data on the next slide. But it's important to note here that there's relatively little data on topics that are relevant to supporting successful and healthy aging for African populations. Data on topics like cognitive health, emotional and behavioral mental health, climate vulnerability, caregiving, economic circumstances, all of these issues that are certainly we can agree are critical. Now, as you may have noticed on the previous slide, among countries in Africa, Kenya is one of those countries that's projected to experience some of the most rapid population aging. And I'll go back for a second. Kenya, of course, is the country here that's depicted by the green arrow. And we can see that, of all of the countries that are in that less than 7% over age 60 category, very few of them take on a dark blue color by 2050. There are a handful, Kenya being one of them. And actually what Kenya is projected to experience is a 4-fold increase in the over 60 population in just 3 decades for all of the reasons that we've enumerated. Now, there are certain really key data gaps and certain key issues that coincide with this population aging. We know that throughout Sub-Saharan Africa, there's this double burden of disease. This refers to sort of more traditional causes of mortality and morbidity in that part of the world that have been maternal, neonatal, nutritional, and infectious, but also diseases that we might call diseases of aging, certainly non-communicable diseases. And we don't really have great data from many locations in this part of the world about age-related conditions like dementia, for example. The projections that we have often lack grounding in local and regional data. We also don't understand very well the economic implications in a lot of these settings, in particular Kenya, of an increasing dependency ratio, of caregiving needs, and of increasing healthcare costs as populations age. Now, one of the keys to addressing these issues, because this is not a phenomenon unique to Kenya, over the years has been the health and retirement study and its harmonized family of studies around the world. And many people in this room are no doubt very familiar with HRS, with many of the HRS studies around the world, have used the data and helped to create that data. And these studies have really been instrumental in shaping our understanding of later life health and resilience factors, informing knowledge around economics, retirement, and wealth, both here in the US, but also in countries around the world. The HRS Around the World Network's constituent studies represent over 40 countries now around the globe. And when taking into account their representation, their population representation, they're believed to represent over 70% of the world's age 60 plus population, which is pretty profound. These HRS studies generally have shared values around public release of data, collaboration and knowledge exchange through the network and through symposia and meetings, and harmonization of measures across contexts. And that could be a whole talk unto itself around how we harmonize these measures without duplicating a measure from one context to the other, but adapting it to unique linguistic and cultural contexts. This approach permits cross-national comparisons that allow us to really better understand the ways in which context and differences in exposures shape population aging trends at the population level as well as individual trajectories. Then we also have the Harmonized Cognitive Assessment Protocol network and family of studies that's been very instrumental in a very similar way, but with specifically focusing on cognitive health and dementia and risk factors for dementia and cognitive decline. And the HRS and HCAP families of studies are illustrated here, and there's sort of color coding to illustrate if there's an HRS study, an HCAP study, both. But what you'll notice is that there's relatively impressive geographical coverage around the world, but that there certainly are some areas where data is more scarce than others. And if we look to Africa, the study in South Africa, known as HALSA, is well established, and the studies in Kenya and Egypt, in yellow, the only two other countries highlighted in Africa, are new and getting off the ground right now. There is an existing HCAP study in Kenya in a follow-up of a randomized controlled trial cohort. So this is a relatively unique HCAP, use of HCAP in Kenya that's not population representative and is pretty distinct from what I'll be talking about us doing in LOSHAK. But the fact that that study exists provides some interesting opportunities for collaboration with the other HCAP study in Kenya. So moving back to the Kenyan context, I'll turn my focus to talking more explicitly about the longitudinal study of health and aging in Kenya. And I'll take you through the genesis of LOSHAK, starting with its initial conception up to where we are today and even projecting several years into the future as we prepare kind of at this point to launch wave one of the study. So the genesis of LOSHAK really began about 6 years ago. So at that time, the Center for Global Health Equity here at the University of Michigan was coming into being through a large donation from a private family. And one of the first partnerships that CGHE set up was with Aga Khan University in Kenya. And as that partnership was being developed, we did a lot of sort of brainstorming and listening sessions, trying to understand how AKU would benefit from this partnership with Michigan and vice versa, and really where the synergies were and where the priorities were for AKU. And population aging really rose to the surface very, very quickly for a number of reasons, largely the demographic issues that I've illustrated to you, but also because AKU acknowledged that they didn't have a lot of capacity and experience working in that space, but they knew that we did here at Michigan. And so this seemed like an area ripe for collaboration. So at that point, I had been doing work in Kenya for a number of years, and so I was involved in these conversations and began talking with my colleague Anthony Ngugi, who's my co-principal investigator on LOSHAK now, and we started forming a team and started brainstorming and thinking about how we might address this. We applied the subsequent year for an R21, to carry out feasibility work to see if we could put together the underpinnings of what might become a larger population-based study to look at population aging and issues of health and economics in Kenya. We were fortunate to acquire funding from NIA to support this feasibility work, as well as seed funding from CGHE, which was really instrumental at this very early stage. And we based the feasibility work in Kilifi, Kenya. For those who are not familiar with the geography of Kenya, Kilifi is on the coast, just north of Mombasa, and south of the Somali border. And it's actually illustrated on the next slide, so stay tuned. And then 2024, we submitted a funding application to fund Wave 1 of LOSHAK, which is a large application to fund both the core study as well as the HCAP study. And thankfully last year in September, LOSHAK was funded as a collaboration between University of Michigan and Aga Khan University, and also in collaboration with governmental entities in Kenya, including the Ministry of Health and the National Bureau of Statistics. And I'll talk more about our partners as well. So as I noted, the seed funding from the Center for Global Health Equity here at the university was really, really critical at this early stage for being able to assemble a rich multidisciplinary team. One of the exciting things about these studies is that they bring together people with so many different disciplinary backgrounds, and even within disciplines, people with such different topical expertise, which is really quite necessary to be developing a study that's broad and looks at many aspects of health and well-being and economics in later life. So we were able to assemble this team, and then we were able to collect some feasibility data within a health and demographic surveillance site on the coast of Kenya in the area illustrated here. And I'll talk about why we sort of leveraged that HDSS in a moment. We focused really on what we anticipated would be the most difficult things to do in a full-scale rollout of LOSHAK in the future. And that was collect data on some of the domains, survey data, that's really challenging to adapt. Measures like measures of cognitive health and of psychosocial well-being, things that are really sort of culturally bound and difficult to translate culturally and linguistically, as well as collecting biomarker data. We wanted to see, will people give us blood readily? Will people wear monitors readily? We just didn't know the answers to these questions because it hadn't really been, well, we hadn't investigated it and we didn't know if our team was up for it. So we recruited 208 participants, roughly split between males and females, and roughly split between people living in urban and, or excuse me, in peri-urban and rural areas. We didn't have any urban dwellers in the sample. As I said, we embedded this in this existing HDSS site, and the reason for that was we had relatively small funding, and we had full enumeration of the population within the HDSS site. We knew where people lived. We knew we could stratify them on some of these basic demographics, and so we could sample really purposively and really kind of know what we were getting. And we felt like that was a really good way to kind of establish feasibility. And so we adapted survey instruments from other HRS and HCAP network studies, particularly those carried out in other low and middle income settings, like LASI from India, HALSA from South Africa, and MHAS from Mexico, 3 studies we continue to draw on quite a bit. And we collected dried blood spots. You can see the dried blood spot card in one of our enumerators' hands here, and wearable air pollution sensor data. I'll talk a little bit more about that. And we learned a lot that was really helpful for preparing for Wave 1 of the study and for writing our application for Wave 1. Much of what we learned in this fundamental foundational stage of LOSHAK was around how to perform field work in a really challenging, austere setting, how to adapt to the needs and expectations of our participants, which were, to be honest, quite different in many cases from the expectations that we held. How to contextualize methods and measures to a rural, low literacy, low education population. And some of these, like the assessment of cognition, were particularly challenging in a setting like this. And just to give you a little more context beyond what's illustrated here, the median income was around $30 a month of the population sampled here, so a very low income population. low education, relatively low literacy. There was not a lot of infrastructure. A lot of households had no electricity. We're walking 3 to 5 kilometers to get water from a central water store. So it gives you a sense of the environment in which we were trying to establish feasibility. Additionally, there were many challenges that we faced in the field that we were forced to adapt to and to design solutions to address. So for example, many houses lacked electricity, and having visitors in the houses was considered taboo. So we had to find clearings and areas where we could actually, we could interview people under a tree, for example. It was incredibly hot there most of the year in this area, but away from the children playing and away from the livestock. And so we really had to sort of establish protocols around where should we be looking, how should we be looking for ideal places to interview people. We had to suspend testing during certain times when harvesting was happening. People were in the fields, even adults were in the fields and not available to participate in surveys. The rainy season was not really conducive to conducting interviews because our interviewers weren't welcomed into the home and nobody wanted to sit outside in the rain for a long interview. We used same gender local enumerators who knew how to dress appropriately, knew the greetings, and were accepted by the communities. And there was some sort of back and forth, adapting digital tasks to pen and paper. And I'll talk about that on a future slide as well, why we had to do that. But all in all, measures were well received. We did not find a lot of interviewer effects. People accepted giving us biosamples, the dried blood spots, and they wore air pollution monitors, and they were actually quite interested in it and learning about it and really quite accepting of it. There were relatively good measurement properties around the adapted survey instruments. Some of you who are psychometrically inclined may notice some of these marginal reliabilities look a little bit lower than we might want. That is true, and that was largely related to having relatively few cognitive items in certain domains and not covering the full range of the latent trait. But with a bigger battery, we certainly will be doing that in the future, and those are some of the learnings that we took. So there are opportunities to improve psychometric properties, and we'll be looking at those also as we do pilot work leading into the full-scale Wave 1 data collection. So we also looked at associations in this non-representative sample, and we've published some data looking, for example, here at associations with self-rated health, showing that older individuals in this population seem to perceive their health less favorably than younger individuals, and also demonstrating a significant role of psychosocial emotional factors in the perception of health. I mentioned air pollution before. So this is what the air pollution monitor looked like. This is the Atmotube Pro. And these were worn either around the neck or they could be attached to a belt and worn around the waist. And we had a subsample of participants, 34 participants, who wore these for 72 hours continuously, collecting air pollution data, whether they were at their jobs, in their home, cooking, whatever. And they were about half male, half female. And you can see here, these are averages graphed by time of day on the x-axis. And this is PM 2.5 concentration on the y-axis. And what we saw was that this again is establishing feasibility, that these data make sense, they have some face validity, we're able to get the data, people were willing to wear the pollution monitors. And what we found were that there were distinct peaks, a lower peak here around 10 to 11 a.m., and then a high peak here somewhere between 6 and 8:30, 9 p.m. And these roughly correspond to times when people tend to be cooking. And there were very gendered patterns to this exposure, where women who traditionally prepare meals in this area were experiencing higher levels of air pollution exposure. Of course, that has massive health implications, and we'll have a lot more data on that. It's an area of great interest of ours in Wave 1 of the study. The issue with this monitor is that, which we learned in the feasibility phase, is that there are potential issues with ceiling effects. Probably wouldn't be pertinent in our environment here reaching a ceiling effect, but if you are hunched over a cook stove in a poorly ventilated house where you're cooking with a biofuel, you reach a ceiling effect relatively quickly, and you're not able to discern the actual concentration of PM2.5, PM210, PM10, volatile organic compounds, and the like. So we are switching to a different pollution monitor in the rollout of Wave 1 that's not as prone to the ceiling effects because it uses a different method for ascertaining the concentration of particulate matter. So with the lessons learned, and those are just a few from the feasibility study, we were, and obviously I'm skipping over a lot when I say we were able to acquire funding from NIA to launch Wave 1 of LOSHAK. So going from this relatively, this 208-person sample down here in Kilifi to really nationally, thinking big. In thinking big, we needed to expand our team even more. And so we have a large team of collaborators in both Kenya and in the United States. Here, so notably from not only the academic sector, but as I mentioned before, from the Kenyan government, from the Division of Geriatrics in the Ministry of Health, the National Bureau of Statistics, which does a lot of sampling and uses the National Census to develop sampling frames. And then here at U of M, here at ISR, including SRO, who's intimately involved in the project, at the medical school, the School of Public Health, the School for Environment and Sustainability, and other units, and many other universities here in the United States, really bringing together deep and broad expertise to diverse content and methodological areas that we need expertise in for the project. And so our long-term aim, what we're really trying to do here, is to develop a population-based longitudinal panel study on health and economics and aging in Kenya, harmonized with these global HRS and HCAP networks of studies. And these objectives, which largely map to our aims from the grant, are to investigate relevant exposures, risk factors, and associations with late life health, disability, and economic circumstances, to estimate the national prevalence of dementia and relevant risk factors, to disseminate findings, of course, and generate data for cross-national comparisons with other studies in these networks worldwide, to plan, of course, for future waves of data collection, because the data becomes so much more valuable when we have future waves and we can look at trends and trajectories. And really importantly, we have a very robust plan to strengthen capacity in Kenya across all areas of the study through training at the graduate level, at the postdoc level, at the faculty level, in fields as diverse as survey design, aging research, field operations, cognition assessment, biomarker science, air pollution science as well. And so really we've built this capacity strengthening into all aspects of the project, which we're excited about. And so when we talk about Wave 1, we're really in some ways talking about two studies. The parent study is the LOSHAK core study. This is going to be a nationally representative study of Kenyan adults aged 45 and older, and the estimated sample size will be around 6,500 individuals coming from all 47 counties of Kenya. And the focus will be broad, like any HRS study on health and economics and later life well-being. But then we have this LOSHAK HCAP study, which is regionally representative. And I'll talk in a moment about why we wanted to go with regional representation for the HCAP. The sample size will be about 2,300 individuals. And this will be focused on the 8 counties that comprise the coast region of Kenya. And there'll be about 30% overlap with the core. So there'll be people who are in the HCAP who are not in the core. And the focus here is on cognitive health, dementia, and relevant exposures for those outcomes. Just to better illustrate here with the Venn diagram what's going on with the sampling, the reason that we chose to do the HCAP on the coast is that we're already dealing in the core with about 12 languages that we're translating all of our instruments into, which is a big undertaking. The coast is largely a Kiswahili-speaking population, and we can get away with many fewer languages by implementing the HCAP in the coast first, and really getting everything right there before we do a national rollout. So we really want to focus on getting things right in Kiswahili in the coast, and then in the next wave, what we plan to do is continue the oversample in the coast as we go nationally representative. The fact that we have this 30% overlap, though, is very valuable. The reason it's valuable is that many of the cognitive measures, or some of the cognitive measures that are in the Harmonized Cognitive Assessment Protocol, the big battery of cognitive measures, will also be found in the core. So this allows us, this overlap then allows us to estimate at a national level dementia prevalence and cognitive function at a national level, even though we only are collecting HCAP data on the coast. So it's that overlap in measures that's really key. And this will represent the first HCAP in any population representative sample in Kenya. And our plans to estimate dementia prevalence are to use a relatively well-described, well-used throughout the network approach that uses robust norms to figure out who's classified as having dementia, mild cognitive impairment, and normal cognition. And so the other study components and measures we have. This is SRC. We have lots of survey instruments, of course. So the domains that you might expect, but also a couple innovative domains, and I'll talk about some of that on the next slide. We'll collect anthropometrics and physical measures. And we're actually going to do venous blood sampling rather than dried blood spots. And the reason for that was our ability to really perform with high fidelity a wider range of assays using venous blood, and a number of HRS and HCAP studies have gone this route for just that reason. But also because our partner, the Kenya National Bureau of Statistics, actually has experience collecting venous blood at a national level and establishing a cold chain for transport throughout the country. Interestingly, we don't know if it'll come to fruition, but we're also looking at possible use of drones to transport blood around the country, which is a potentially exciting innovation. And we'll be doing more wearable device measurement, not just of air pollution exposure, as I mentioned, but also accelerometry to ascertain physical activity. And these are in both the core and the HCAP samples. When it comes, I should have mentioned this before, when it comes to the blood, we're doing a host of what one might consider sort of standard assays focused on things like inflammation, HIV, nutrition, but then we're also banking blood for future genomic studies, as well as for more advanced ADRD biomarkers, dementia biomarkers. So some of the innovations that I wanted to highlight here are a focus on herbalism and alternative medicine. So Vicki Ellingrod, who's the chair of the College of Pharmacy, is involved in LOSHAK, and I should have included pharmacy on that prior slide where I mentioned our collaborators at Michigan. But she's helping to develop with collaborators in Kenya a module on herbalism and alternative medicine. She's done a lot of work in Kenya for decades. We're doing really rigorous migration pattern tracking because there's a lot of migration in both directions, both to the city and then in older age back to the rural village in many cases. And so this migration pattern tracking is really important because it impacts on exposures, but it's also simply important because in wave 2, we're going to want to find the same people. So a lot of reason for us to do this, and also just to understand patterns of migration within the country among older adults. And then we've talked quite a bit about the wearable sensor deployment and the advantages there. And so this is relatively small, sorry about that, but this timeline begins kind of where we are today, April 26, and projects out for the next 4 years or so. And so right now we are still in this establishing study infrastructure phase and protocols. We have work groups working on, which Kelly's been so instrumental in, work groups working on each of these different domains. Our team at SRO, Peter and Stephanie and Margaret, I see back there, have been so instrumental in working with our colleagues in Kenya on sampling and on establishing the technical platforms for data collection. And then we hope that early 2027, we'll be out doing pilot work, making sure our measures work, making sure our field protocols work and our technical systems work. And then we'll be rolling out in phases, the LOSHAK core survey, the LOSHAK HCAP, and then ultimately disseminating data. And throughout, we'll be strengthening research capacity. I'm going to shift gears a bit and talk about really the United States and why LOSHAK is important for the US. And I think this has really become an increasingly important topic, I think, for us to be thoughtful about as we discuss the relevance of our work, because it really is quite relevant for US populations. And it turns out that it has implications not just for how context shapes aging trends and how we understand context, but also for methods and measurement. And I'll talk a bit about both those things. So we know that there's a relative health disadvantage for older adults in the United States compared to some peer nations. And some of the sort of facts underlying that health disadvantage are illustrated here, articulated here. We know that in the United States, for example, later life financial volatility may confer cognitive risk, whereas social safety nets and guaranteed income, we've seen through other HRS studies, can serve as a cognitive buffer in settings like England and Mexico and South Africa, rather diverse settings. We know that labor market participation, including policies that promote supportive workplace environments, can buffer against dementia risk, and we take some of that evidence from South Korea. And so these are just a few examples of areas where data from other countries with distinct social and economic and policy environments can help us to better understand health and wealth in later life in the United States and policies that may be adaptable to help promote those things here in our context. And so the way to think about it really is that these harmonized networks of studies can provide a global mirror that allow us to better understand our health here at home. And it's important to note that these studies continue to be well supported by NIH, by NIA, even amidst these funding shifts that we see. And so hopefully that will remain the case because we've already learned quite a few lessons from LOSHAK that we believe are applicable to US populations. The LOSHAK study, as I mentioned before, really faced, the feasibility study faced profound hurdles for measurement. Linguistic diversity, distinct cultural norms, and a population in our feasibility study where 60% had no formal schooling. Illiteracy rates very high, and numeracy rates very high. And this fieldwork can really teach us something. Replacing generic phrases with those that are culturally resonant really makes a difference. We have an example here of a Swahili phrase. This is the replacement for no ifs, ands, or buts, which is a common phrase repetition that happens in cognitive testing. I won't try to say it. We found that we need to be really flexible in our administration. Sometimes tablets made more sense, but in other cases, we had to be flexible and offer a paper version. But we found that we were able to maintain relatively high reliability despite these adaptations. And we believe that the contextualization framework emerging from LOSHAK really has relevance for low literacy populations here in the US, populations that are non-English speaking or have limited English speaking proficiency, and those that are marginalized and may require different types of, for example, language that's culturally resonant in order to really facilitate good measurement of the things that we want to measure, not people's understanding of the question or not people's cultural interpretation of the question. And so we're hoping to develop this measurement framework even more as we continue in the field in LOSHAK, because we do think there's a lot of relevance to the US, but also to other settings. And so to conclude, we believe that Kenya is a really vital setting in which to study health and economics and population aging, vital because of what's happening in terms of demographics and epidemiology in Kenya, but also vital for Sub-Saharan Africa. In many ways, Kenya is about a decade ahead of some of its neighboring countries in terms of demographic and epidemiologic transitions. But as I've illustrated, it also has relevance to how we think about certain populations here in the United States and elsewhere. These contextual factors and exposures and policies, which some term the exposome, we know play a large role in shaping later life health and economic circumstances and well-being. But understanding exactly how these things play out in Kenya is going to be vital for policymakers and public health planners and economic planners to ensure success over the coming decades. This global variation is not only interesting, it's important, and it allows us to understand how policies matter. And the measurement challenges and solutions, while frustrating on the day-to-day scale, are hugely important and hugely interesting when we take a step back and really learn from them and apply to other populations, other settings, and to making sure that we're measuring things with as high fidelity and reliability as we're possibly able to. And so with that, I will stop and leave time for questions and discussion. Yeah, Mohammed.
Yeah, I know that the E25 that he collected for 34 individuals, and is there any way that use that data extrapolate to the rest of some of the 200 something individuals use the same?
You mean basically to impute pollution exposure for the remaining part of the sample? Probably. That's not something we've undertaken, but probably. Yeah. I would think so. There's a lot of similarities between. We tried to sample sort of peri-urban and rural in relatively equal proportions, both in the air pollution monitors sample as well as in the sample at large. So I would think so, but just not something we've undertaken. You'd probably be the right one to do that, right? Yeah. Any other questions or Kate?
I just wondered within sort of the structure of your data collection, if you've thought about doing anything like ecological momentary assessment or sort of getting, potentially in the moment responses on things like depressive symptomatology, loneliness. Would we have a possibility to geocode those data? I just wonder if there are any discussions around that.
Yeah, we have talked about that, and that's some of the decision making that we're actually doing right now with our thematic working groups. We have a psychosocial thematic working group, are really around sort of refining the measures and striking that balance between how much time can we spend on each domain versus how much data are we possibly able to get. And yes, I think there's a lot of value to ecological momentary assessment like that. Yeah, thank you. Any other questions? Yeah, Peter.
Are there any other countries in Africa that express interest in something similar? I think the other country we had highlighted was that Egypt.
Yeah, Egypt. And so the South African study has been around for quite some time, as you're aware. But yeah, and Lindsay may even be a better person to answer that question. But as far as I know, besides Kenya, there's interest in Ghana, Cote d'Ivoire, Congo.
NIA has funded pilot studies of the HCAP, and this is not necessarily like the full HRF study that LOSHAK is in Ghana, in Cote d'Ivoire, in Cameroon. There's a smaller sort of Alzheimer's Association study in Congo and DRC, and Botswana as well. And there's also an embedded HCAP in the Malong family life study. So there's sort of like seeds growing.
I heard really interesting news from Rwanda is becoming very progressive and an interesting country. I was wondering if they were on the list somewhere.
Yeah, I co-direct the HCAP network, which is why called me. So we work with a team from Rwanda to put some applications in, but nothing's been funded so far. There is interest across various actors.
Thank you.
So I think one challenge of these late life studies is to measure exposures that these people experience early in life. And with the setting like Kenya, how much information can you get from for that?
I mean, it's hard. There's certainly policy data is relatively accessible. Climate data, sort of large scale ecological exposure is relatively easy. But in terms of sort of like linking to administrative records and things like that. That's extraordinarily difficult. Extraordinarily difficult. There may be for the more urbanized fraction of the population, we may be able to do a little bit more of that, but it's going to be extraordinarily difficult. Then there's sort of there's interview and recall bias, but we're not going to have the same accessibility of administrative records like you would have in a Western country or a country that experienced urbanization and more of a formal healthcare system longer ago.
Were you selecting your sample? Because I feel like for a person who lives in a rural community, you have to send like a person out there to like record that data.
Yeah. There's a national census with full enumeration of the Kenyan population. So we're basing it on that.
I mean, like, so if there's like one person that your sample selects, you send out like one specific person.
Yeah. I mean, we have clusters, but yeah, we have to send enumerators all over the country. Yeah.
Tell us anything about your data collectors. Single trained cohort, if you have local trained.
Yeah. So the data collectors are hired, and they're hired by KNBS, the National Bureau of Statistics, and they will be jointly trained by KNBS and SRO. The enumerators are largely people, if not the exact individuals, then kind of pulled from the same cohorts, who've gone out and done other studies with KNBS around the country, AIDS indicator surveys, WHO STEP surveys, these kinds of surveys around the country, the census. And so they're pulled from local communities because we need enumerators that speak local languages and that can observe local customs. So community sensitization and community interaction is a really important and core part of what we do. And I didn't get really deep into that, but our collaboration with the Ministry of Health, the Division of Geriatrics in the Ministry of Health, is really, that's one of the main sort of aspects that they're undertaking, is this community sensitization and community entry, meeting with village elders and chiefs and decision makers. But part of that also is choosing enumerators who are attentive to local norms and speak the local language. Yeah. And thankfully we have KNBS, because without them that would be another Herculean undertaking in addition to the Herculean undertakings that we already have. Yeah, Kate.
So is it also seen as something that provides employment opportunities then for the community, and just imagining that gives it a positive.
It absolutely does. And Aga Khan University, our collaborating institution in Kenya, has actually published quite a bit. Some of it in collaboration with the Ross School of Business, about the economic implications of the work that they do in the health sphere in Kenya, looking at how many jobs, not just direct jobs like enumerators, but also they buy supplies from this local business, and then they need transport and all of this. And they've done a lot of costing and showing how the sort of positive ripple effects of their research kind of pervade society, which is wonderful.
If you wouldn't mind hanging around for a few minutes, maybe people will come up for a more informal conversation with you.
Thank you. Well, thank you all very much.